Just a second, please. Okay, we will share the screen a second. All right. So we'll crack on now. Candidate 1, your time starts now.
Okay.
You are going to be presented with a chest X-ray of a gentleman with sudden shortness of breath. Okay? Whether it's a gentleman or chest X-ray patient with acute shortness of breath.
This is the X-ray chest frontal projection of a patient with acute shortness of breath. Here I can see there is a homogeneous opacification is seen in the right hemithorax. Possibility of underlying ribs cannot be excluded. I will zoom the images to see the underlying rib destruction. The right hemidiaphragm and right heart border is obscured. Right CP angle is blunted. Left lung appears normal. I will compare these findings with the previous X-ray, if available, and I will ask the history of the patient exposure to any industrial worker to exclude underlying mesothelioma. I cannot see any surgical clip which suggestive of any pneumonectomy. I could not see any obvious rib destruction. However, in my normal routine practice, I will zoom the images and to see the further detail of the rib. So in summary,
how much zoom you want now?
Yeah, now it is okay.
Okay.
Yeah, okay. So there is no obvious rib destruction. So can you do it as a short, small in size? I want to see the CP angle in last. Yeah. So there is a in sum up there is a homogeneous opacification in the right hemithorax with obscuration of the right heart border and right hemidiaphragm. This may represent with curvilinear opacity, curvilinear operation. This may represent a large pleural effusion on the right side. However, possibility of underlying mass lesion cannot be excluded.
Sorry, what cannot be excluded?
Underlying mass lesion, underlying mass.
Underlying mass lesion, okay, cannot be excluded. Okay, what else?
Yeah. So this should be either compared with the previous X-ray or further indicated that CT chest.
The patient is not registered in this hospital.
Okay. And I will ask the patient or history of history of any exposure, any industrial workers, and age of the patient. I will also.
Patient is not registered. He came with acute shortness of breath and is not able to talk. Is acutely short of breath, as mentioned earlier.
Okay.
So what is the differential? You just mentioned the differential is a large pleural effusion or mass.
Yeah, this will be a large pleural effusion. I will do the CT scan chest.
Okay. What do you want to exclude on CT chest? You already seen.
I want to exclude any underlying mass lesion, any mesothelioma, any rib destruction, any underlying mass which is obscure on this because in the chest X-ray we cannot see the large pleural effusion. Possibility for underlying mass should be excluded by the CT scan chest.
Okay. Anything else you can see on this X-ray before we proceed to CT scan?
There is small trachea and mediastinum is shifted toward the right side, minimal, and I'm trying to look
towards the right side. Did you say?
Yeah, this mild shift is of trachea toward the right side.
Sorry, I cannot hear you properly. So what did you say again? Can you come again?
The mild shifting of trachea is seen toward the right side. Mild, minimal shifting of the trachea toward the
So
right.
trachea shift towards the right side, did you say?
Yeah.
Okay, so large pleural effusion on the right side and tracheal shift towards the right side. How do you explain that?
This may due to loculated empyema can sometimes can be present like this shifting of the trachea toward the right side when there is loculated effusion.
Okay, so you want CT scan.
Yeah, I want looking the spine, but I could not see the spine. Retrocardiac area, there is no opacity, so I will want to see the CT scan.
Okay. So can you see just the CT scan, or can you see the side windows thumbnails as well?
There is CT scan I can see.
Or you cannot see any thumbnails along
No,
the border. Okay.
no.
So that's the CT scan for you. I'm going to give you the remote control.
Okay. I guess.
All yours.
Okay. This CT scan shows the non-contrast images. First of all, I will scroll all the images from the top to the bottom. Then I will be able to describe my findings.
So you mentioned CT scan of the chest, yeah?
Yeah. This is a non-contrast CT scan chest. Here I can see there is a moderate pleural effusion is seen. The underlying right lung appears collapsed with high index suspicion of large mass lesion in the right lung. I want to see the on the lung windows also. First of all, it's should be completed. I will compare it from the top to the bottom. So in the visualize section is non-contrast section. I can see there is a pleural effusion with the underlying.
You can ignore abdomen and pelvis for the
Okay.
sake of time. And I would suggest you to concentrate on chest, please. Thank you.
Okay. So I'm going back to the chest images. The image is a little bit slow. So there is a moderate to large pleural effusion is seen on the right side. And there is under hyperdensity area is noted medial to this pleural effusion. This likely represent underlying.
Can you show me with the pointer which area you're referring to? Okay, so what is that?
This likely represent underlying collapsed lung, right lung. So I will want to see the
right lung.
Yeah. So this could be mass in the collapsed lung. I want to see there's a mediastinum is shifted toward the left side. I will also the lung window, left lung appears relatively normal. However, mediastinum is shifted toward the left side. I will
Can you scroll it for me, please? Can you scroll it and show me as you're commenting on? Can you scroll it?
No, I cannot scroll it.
Yeah.
Yeah. So this is the we can see the left lung. The mediastinum is shifted toward the left side, and left lung appears normal. However, my routine practice, I will also want to see the with contrast images.
Okay. There you go.
Yeah. This is not. There is multiple. So it is not scrollable. Yeah, no, it is scrollable. There is multiple small soft tissue. Yeah. So in this post-contrast images, here I can see there is underlying collapsed lung, and there is no discrete mass is seen. However, the right upper lobe bronchus appears normal. Middle lobe bronchus appears normal. The right lower lobe bronchus I could not see adequately. This possibly maybe there is some element of the collapse in the right lower lobe. So if the patient has history of weight loss and if the patient has the malignancy suspected, then this patient may needs endobronchial biopsy to exclude any underlying obstructive lesion.
Okay.
As we don't have previous record, as we don't have the patient history, so the patient should be managed according to the patient current status. If the patient is having history of loss of appetite, a patient has history of weight loss, then the
Okay.
should be managed to
So
bronchoscopy.
what you recommend in this? You are the registrar on call or acute concern on call. This scan is obviously reporting, and the radiographer is calling you, sir, Doctor So and So. This is the patient. Patient is in the table. What do you want to do? Anything else? Are you happy with these images? Can we send the patient back to ER? Okay. So in your report, you're going to mention about the MDT, right?
Yeah,
Is that
discussion
what you want
MDT, the discussion in MDT, and urgent discussion in MDT, and endobronchial biopsy should be considered. The patient has
Okay.
symptoms of the weight loss and diet history.
Okay. So while you are describing to your colleague, concerned colleague from ER, who is very keen to know about this patient status, and you are going through the images with him or her, you got to know, you got a crash bleep that patient is collapsed while in the CT scanner. Any thoughts?
There may be the patient has pulmonary embolism, so we do the pulmonary artery angiogram to see the pulmonary emboli.
Can you see the pulmonary arteries here in this scan? So
Yeah,
there's no central pulmonary embolism, yeah?
This main pulmonary artery, there's no pulmonary embolism. Yeah.
Okay. Okay, that's fine. We'll move on, I guess.
Okay.
Okay, thank you. So I'm going to give you the next one. Okay. So here's the patient. Let me share the remote control. Patient's complaining of long-term, long-standing left flank pain.
Patient is going long-standing left flank pain. Okay. Yeah, this is a CT scan of the non-contrast, probably CT KGB. Images are taken from the kidneys downward. Here I can see the large cyst is noted in the upper and mid pole of the left kidney. There is no evidence of any septation. No calcification is seen in it. I could not see any radiopaque calculus in the kidneys bilaterally. The ureters are traceable. I'm going inferiorly to see the status of the urinary bladder. However, I think images are not included urinary bladder. So here I can see in the summary, there is a large renal cyst as seen in the upper and mid pole of the left kidney. This appears to be it is a benign cyst. No further action should be needed in this regard.
Okay. Do you want to reconsider your initial thoughts?
Yeah.
How would you differentiate a benign cyst with hydronephrosis on non-contrast CT?
There is a
How
mild
easy?
hydronephrosis. There is cyst as well as there is a minimal hydronephrosis.
Can you show me? Can you show me the hydronephrosis, please?
Mm, yes, this one, here.
Okay.
This one, this one.
Okay.
This is a large cyst. I think this is the right kidney is compressed. And if I will see I want to see the coronal images, so that will be more obvious if coronal images are available.
I
So
give you
this
with
is
contrast
okay.
to make life easier for you.
Yeah, this is a thanks. This is a post contrast images. It's not scrollable. Yeah, not scrollable. So in this post contrast images, yeah, there is moderate hydronephrosis. It is more marked as compared to non-contrast images, and there is also some heading suspicion of this upper pole cyst in the approximately 4 to 4 centimeter. I could not see any septi in it, and I could not see any cause of this hydronephrosis. If it is,
You think it's a moderate hydronephrosis?
yeah, moderate hydronephrosis. And
Okay.
there is one suspicion is that this could be, say this could be whole hydronephrosis. So this may be due to PUG obstruction, previous age of, I will know the age of the patient, I will compare with the previous studies, because I could not see any stone. And if the patient in long-standing left flank pain, and these finding may be present previously, so this could be PUG obstruction on the left side. I will ask these findings should be conveyed to the
So is it a large cyst? Is it a PUG obstruction or just hydronephrosis?
um, I think this is a hydronephrosis with upper pole cyst.
Sorry?
Hydronephrosis with possible upper pole cyst.
Okay.
The possible upper pole cyst in the left kidney.
Okay. What would you do next?
Next, we do the ultrasound of this patient.
Ultrasound. How ultrasound is going to help you?
In ultrasound, we can see the cyst as a differentiated hydronephrosis.
Is it easy to differentiate a simple cyst with hydronephrosis, a large hydronephrosis on ultrasound?
We can have the idea, and second thing is that we can do the if the patient has a renal function is not normal, if the patient is deteriorating renal function, we can see the nuclear scan to see the renal function test.
Okay. Anything on CT scan would you like to do?
What is the house? What we take the density of this cyst as well as the hydronephrosis? House field genetic can be measured.
Anything else? Anything else?
We can do the surgical images. See the
Look, anything on this image, is this particular image where you are right now is telling a story.
We see the communication. If there is no communication, that could be a cyst in upper pole.
How you see the communication? Okay. Okay. So you asked for the nuclear scan, right?
Yeah.
Okay. Okay. Which test is this?
This is, I think, a DMS scan.
Okay. So DMS scan, do you think?
Yes, DMS scan.
Okay. It's a renogram, Mac3 renogram. Okay. What is the difference between DMS and Mac3 renogram?
DMS scan will see the anatomy, for the anatomy of the kidneys, and in MAC3 the function of the kidneys.
What is the basic difference in in the philosophy of both tests?
Here can we see the renogram, we can see the percentage of the function of the kidneys, how much the function right kidney, how much the function left kidney. We can see the curves, and in the this we can in the DMS scan we cannot do the curve, but that is only the see the anatomical orientation of the
Okay.
kidneys.
Okay. So please, can you comment on this particular Mac3 renogram?
Here on the posterior images, I can see the function of the right kidney appears normal, however, non-visualization of the left kidney. The right ureter also appears normal. The left ureter is also not seen. So this is appears to be non-functioning left kidney.
Okay. Any comments on this particular?
This is the renogram. This is the right kidney curve is going inferior spirally, and then it's fall down. There's the peak.
Sorry, can you please repeat again this? What did you say?
The first curve I see, there's two curves. One is
Can
the
you point on the curve with your mouse? Thank you.
Yeah, this is I think this is the right kidney curve.
I cannot see the mouse on the screen. Okay, I will take it. Control. So which
Yeah,
is this? Which kidney is this?
This is the right kidney.
This is right kidney. Okay, and this is left kidney.
And this is the left kidney.
Okay, and what does it show?
Left kidney shows probably non-functioning kidney, and right kidney shows proper function.
Okay. So why there's a dip here?
This normal dip, they give the this diuretics, and there's a sudden drip.
Okay, that's fine. Thank you. I think with the interest of time, I'll stop you over here.
Okay,
because I want to give you the feedback.
Okay,
and then we'll move to Canada. Otherwise, I can take you over for 10 hours.
Okay, sir.
Okay, so what do you think? How did it go?
I don't know, sir.
Sorry?
I don't know, sir. I don't know. First, my Baba, I don't know.
Okay, that's fine. Let me get back to the CT scan first for the audience. Okay. So audience, now we are talking about someone who is having left flank pain, acute left flank pain. Long-standing left flank pain. So somebody who is having left flank pain, when you see this kind of non-contrast study, obviously it's very difficult to differentiate hydronephrosis with simple multiple peripelvic cyst and a large parapelvic cyst. It's difficult. However, there are certain clues even on non-contrast. There are certain clues. Am I sharing the screen or not? Not. I'm not sharing the screen, right? Can you see the screen? No. Okay. Can you see the screen now?
Yes, now we can see. Now we can see.
Okay. So always there are clues here. Even on non-contrast CT, the first clue is see the thinning of the cortex here. Okay, and then you can see the blunting of the cheilitis and fornicis. That's the biggest clue. So basically, this means that patient is having a long-term insult, long-term obstruction, which has slapped which is slapping against the cortex, and over the period of course, over the period of time, the cortex has become very thin to the extent that the kidney might be non-functional. Or even on this non-contrast CT, you can kind of make out. And then you always ask for the contrast scan. So in your case, what I felt that you were trying too much. You kept on saying parapelvic cyst, large cyst, parapelvic cyst, large cyst. It could be hydronephrosis versus parapelvic cyst. And then you kept on describing there's no stone, there's no blah, blah, blah. But you were very I would say it's a classic scattergun approach, where you talk about calculus, then you talk about hydronephrosis, then you talk about large paralysis, again you talk about hydronephrosis, then you talk about what do you call it, ultrasound. Once you try to interrogate, then you say, okay, I need coronal images. What I was trying to get from you is I want a contrast enhanced CT scan and I want a urogram, excretory phase. So this is a non-contrast phase. Then I want a nephrogenic phase. Then I want a urographic phase or excretory phase. So that's the classic three phases of the urogram, where you clearly identify where the contrast is being absorbed and then excreted. So whether the kidney is functioning or not. So, I mean, I didn't show you the excretory urographic phase, but I showed you the nephrogenic phase. You can clearly see here the thinning of cortex, and then again, you can see there's that, there's indistinct margin between this large dilated renal pelvis and then these chalices with blunting of their corners, the borders. So it's a severe form of hydronephrosis, and then you can, if you trace this, so there is a sharp transition point between this and the ureter. There. So ureter basically, even if you track it other way around, see from here, if you keep tracking up, you will see you keep tracking up, and suddenly you see a sharp transition point. So even here, you can say that's a PUG obstruction. Then you can ask for urographic phase. If I give you, it's fine. If I don't give you, it's fine as well. And then you can ask, okay, I'm really concerned about the function of this kidney because the cortex is very thin out. So I need to assess the function through the MAC3 renogram. And now, when I showed you MAC3 renogram, there were two things which I would like to point out. And I'm giving you this feedback so you don't commit this mistake in the exam. Okay, so when I gave you this was the first screen in front of you. And what does it say on the tin? It's a tin, yeah? On the tin, what does it say? Renogram.
Screen is not available, sir. Not available.
Okay, so, okay. Yeah, you will have to remind me time and again because I'm quite forgetful in sharing screen. Okay, so here on the tin, what's written here? Renogram. So this image was in front of you. So first of all, this is written here, renogram. Secondly, you see the dynamic nature of this scan. DMSA is kind of static. Here it's dynamic. So you can see over the period of time, it's just draining. Yeah, it's there's uptake, and then you can see the uptake in the kidney. And then obviously this one you describe very well. There's after furosemide injection, there's a dip. So that means the right kidney is functioning okay, but the left kidney is not functioning at all. You use the word probable. You said probably left kidney is not working. It's definitely or certainly left kidney is not working. So try to avoid these kind of. Now, your style, particularly the feedback. Okay, so one more thing now. Going back to the first scan now. Then I'll share the final feedback about you. Okay. Now, when you see, so this is the chest X-ray you got. It's very simple. You talked a lot. You consume a lot of time. So you deprive yourself from seeing a lot of cases. In exam, there's certain time limit. Here, for your sake, I just kept going. In exam, they're not. If they want to show you those 6 cases in half an hour between the 2 examiners, they will either say, okay, that's it, next one. Okay, let's move on. Normally, the examiners say, okay, let's move on. Or they will just keep listening to you and they will not show you all 6 cases. There are only two possibilities. In either case, so you need to move on. If you don't know case, it's better to say, I'm struggling here, when this is my thing, I will seek seniors help, or I will take a help from a colleague. That means you're telling them that move on. I'm stuck here. I'm declaring that I'm stuck here. Let's move on. Why are you wasting time? So here you're finding yourself, you probably kind of dug a hole for yourself here. Here, it's a very simple thing. If were you in position, I would have said that it's a frontal chest radiograph of someone. Always repeat the history. Someone, so that you remind yourself as well. Someone who has acute shortness of breath. Uh, I can see a large kind of almost white out right hemithorax. There's no significant mediastinal shift. There's a very sudden mediastinal shift towards the left side. No significant mediastinal shift. I can see a bit of aeration of the lung there. This probably collapsed lung, compressed by the large pleural effusion. Other than that, the left hemithorax is okay. I do not see any fracture rib. So fracture rib is a key here, whether the rib is fractured or not. Somebody who is in acute short of breath, what are the possibilities? One, trauma causing hemothorax, okay, or pneumothorax, acute shortness of breath. Second, PE. Third, a large mass compromising on the lung functions, and suddenly patient has reached a stage where is exhausted. Um, I can't think of anything else, honestly, which will give you acute shortness of breath or pulmonary edema. So here, when you see, so you can say there's no rib fracture. The next thing you ask is there a history of trauma? I cannot see any rib fracture, but someone who's an acute shortness of breath, trauma should be considered. Is there a history of trauma? Examiner may say, I don't know. Or examiner say, no history of trauma. Then you kept digging, and I kept asking anything else you can see. If I'm asking you anything else, I'm giving a hint. There's something else. Could you see these nodules here? Soft tissue shadows. They're clear here, very clear. In the left axilla as well, but they are hard to pick up here. It's quite easy to pick up here on the right side. Anyway, so even if you don't pick up, you would have said somebody who's acutely short of breath, he warrants you need a CT scan. I don't know the cause, but it could be anything. It could be a large pleural effusion. It could be PE causing massive edema. It could be unilateral pulmonary edema. It could be a trauma. If I cannot see a rib fracture, it could be a trauma and leading to hemothorax. This patient urgently needs a CT scan. That's it. There's not much to say here. And then when you get a CT scan, things become very different here. Okay, I gave you, first of all, let me share the screen before I forget. Okay, so I gave you a non-contrast CT first deliberately to see the thought process. Now, first thing first, you could say it's a non-contrast. Just describe it. It's a non-contrast CT thorax. That's it. And let me take a few moments to go through it. How many seconds it took? 2 seconds, 3 seconds. Then you just keep scrolling. And yeah, you were right to scroll down. I said, no, stop it. Just focus on thorax. Okay, you come back. Then you see, okay, there's a low density or low attenuation effusion. And then there is also high attenuation, heterogeneous high attenuation, something here. And now you are thinking of large mass or God knows what. I don't know what was going on, but ideally you should be thinking of a hemorrhage here as well, high density. High density could be blood as well. High density could be mass, right? So you could say there's a heterogeneous hyper attenuation, high attenuation, heterogeneous high attenuation in the right pleural cavity, and probably the right lung is secondary atelectasis of the right, or passive atelectasis of the right lung. There's a bit of shift towards the left side. Apart from that, I can't make out much. I would like to see in the lung window. In the lung window, you see, not much you can see again. I would like to see in the contrast phase, post-contrast phase. You get the post-contrast phase. This is the money. This is where the money is. Okay, here again, can you see? You just ignored those hyper attenuation within the contrast. Within the pleural effusion, there are streaks of hyperdensity. As somebody is spurting the contrast in the pleural cavity. That's why you are getting different shades of gray here. And what's that? And then what is this? You went past it quite a few times actually. What is this? This is an aneurysm, pseudoaneurysm. See, it looks like aorta. Is it double aorta sign or what? So this is the main aorta. And then if you see, this is just like aorta. Yeah. And then if you just mindful, there's artery coming off here and feeding this pseudoaneurysm. So basically it's a blood intercostal artery into the pleural space. So that's why it's sudden, it's like this. Once it bleeds, the pleural cavity starts filling up with blood. And then, that's why it's different age of blood. So what could be the mechanism? Mechanism could be anything. That's secondary. But here the mechanism is quite evident. Can you see that? Those nodules, those were available on evident on chest X-ray as well. Very subtle though. But here they are, you can't miss it here. So these are neurofibromatosis. So the patient has got background neurofibromatosis. Probably one of the neurofibromatosis was on the pleural surface, and then it just eroded in one of the arteries. That's the assumption. This is my case. It came to ER, and the patient was saved. So there was a urgent call for interventional radiology, and patient was embolized. So it's a life-threatening. It's a life-threatening emergency, which you can't miss. So what is the take-home message? Whenever you see these kind of things, don't get panic. I could feel the feeling of panic. So always look at this. Always look at the shades, and then you can't miss. You can't miss these kind of things. Examiner will not give you this. So again, here there were some critical mistakes done. Collapsed lung, then lung mass, then PE. I would like to see the CTPA, although you could easily see the central pulmonary vessels. And then MDT, cancer, all things came up to your mind. But then, look at the history. History is the key. I just give you 3 words: acute shortness of breath. That's it. And that summarizes everything. So history is always key. Never, you are someone, I think you have knowledge, but I think you need a lot of practice. So you need a lot of practice to shape up your answers as per the question of the exam, as per the scan. And you need to think fast. Think fast, think relevant, think focused, and then execute. Okay. Candidate 2 now.
Yes, doctor, I'm here.
Okay. Here you have scan of an middle-aged person.
Mm.
I won't give you any more history than that.
Okay. So this is a frontal radiograph of both hand in a middle-aged person. I would like to check each hand first. I can't see acute bone injury in both hands. However, I can see there is some pre-osteal reaction noted, um, mainly in. I can see some in the left hand surrounding the second metacarpal bone, and also in the third finger surround the proximal phalanx in the left hand as well. Um, And in the right hand, um,
I've given you the remote control so you can show us as well what you're
yes.
talking about.
Okay. Can you see my cursor now?
Yeah, I can.
Yeah, there's some pre-osteal reaction noted here and also here in the left hand.
So what's
Uh,
that? Sorry, what's that? Can you explain again? What is that?
Periosteal reaction.
Okay.
Okay. Uh, and I will look to the other hand. In the other hand, I can see there's some subosteal bone resorption noted mainly in the little finger in the proximal phalanx, in the radial aspect of the proximal phalanx of the little finger. I'm checking the carpals. I think here the capitate and the hamate, maybe there is a coalition there. There is no distal osteolysis, no significant bone lesion. The joint space are well preserved. Um, So I think I'm thinking now about systemic disease because it's affected both hands with subperiosteal bone resorption and periosteal reaction. I with no acute bone injury or bone lesion. Um, my main differential will be hyperparathyroidism for this patient. I would like to compare if there is any previous imaging for this patient. Um, um, and also uh, check
So in
ask for
primary hyperthyroidism, sorry, did you say parahyperthyroidism or hyperthyroidism?
hyperparathyroidism.
Hyperparathyroidism. Okay.
Yes, this may be
What else?
this may be primary or secondary due to renal renal disease. So I would advise I would check the clinical history of this patient to compare with prior imaging. Um, ask for clinical correlation with the parathormone level, renal functions, and calcium.
Renal function was fine, parathyroid level was fine.
Okay. Mm,
And thyroid levels were fine as well.
okay. So for this periosteal reaction here, um, it's not involving the whole bones. Actually, this may be mm, mm, mm. I'm thinking maybe pachydermocystitis, but I'm not sure about this because it involve only the periosteal reaction involve only these two. What else? Um, yeah, so this might be
Okay, I mean, you've given me enough. What's the next step?
the next step. I will make I will to rule out any abnormalities causing this periosteal reaction. Maybe I'll check to CT if the patient had a CT chest abdomen pelvis to rule any lung pathology or abdominal pathology.
Okay, so what kind of pathologies are you are expecting? What is
Yeah,
most common?
most common if the patient has maybe if the patient has Crohn's or abdominal Crohn's, lung cancer, cystic fibrosis. So I would like to rule all this, if possible, according to the clinical history of the patient.
Yeah, I'm just gonna share a CT scan. So that's the CT scan of the patient.
Should I ask for a control? Yeah. Okay. requests.
No, this is. I mean, there's nothing else to see.
Okay, so this is a CT axial cuts lung window for the same patient, which I can see that there is a well-defined lung mass noted. It appeared like soft tissue surrounding ground glass opacity. Um, in my routine practice, I would like to check the whole stack to rule out any associated other pulmonary nodules, and
No,
also
no, nothing else. What are you going to do next?
okay, and yes, also change to mediastinal window to assess if there's any associated mediastinal or hilar lymph nodes. I can't see anything clear here in the lung window, but usually in my routine practice, I change to mediastinal window, or also change to bone window to rule out any bone metastasis or destructive lesion. I'm worried about this maybe primary lung cancer, and there is septal thickening also noted here. I I would like to check the whole stack of the imaging to rule also if there is any lymphangitis carcinomatosis. My main diagnosis for this primary lung cancer. This patient need to be urgently referred under 2 week with pathway to the lung MDT, and the whole stack of the image need to be checked for staging to rule yes to assess also the pelvis and the abdomen. This patient need okay. Thank you.
Okay. This patient has got ongoing headaches. Okay.
Sorry, doctor, I can't hear you.
Ongoing headache.
Headache. Okay. Okay.
Just a second. Okay. So you have got the remote control now.
Okay. Thank you. This is CT axial cuts for the brain for a patient presented with ongoing headache. I will check the whole stack of the images, then I will give my comment. Okay. In this patient, I have noticed that there is an area of different areas of hypodensity noted involving both frontal lobes with significant mass effect on the bilateral lateral ventricles. And significant midline shift. This is and edema edema in the white matter, giving pathogenic edema more on the right side. And also on the left side. This is likely to be a mass occupying here in the midline, occupying the genu of the corpus callosum as well. And I can see that there is also I'm not sure there's opacification of the and destruction of the bone, which I would like to check also in the bone window extension to there's opacification of the frontal sinuses and nasal. Yes, okay. Yes, there is destruction here noted within the maxillary medial wall of the maxillary right maxillary sinus, and the nasal within the nasal bone with opacification of the nasal bone nasopharynx, opacification of the sphenoid sinuses, and there is a dense opacity noted within this opacification. Also, there is a high density noted within this is frontal sinuses. Okay. And I can see also there is extracranial scalp hematoma noted.
You can ignore that.
Okay. Um, I think also there is a sclerosis seen here and the area of lytic lesions within the clivus and the petrous bone.
Where is the destructive lesion? Sorry.
Lytic lesions, lytic areas seen here. So my main, this is my interpretation for this. This is looks like aggressive intracranial lesion, noted mainly in the frontal crossing the midline. I would like to check this in post contrast if available. Okay, there is avid enhancing of this lesion. And there is also areas of non-enhancing. This may be necrotic areas within the lesion with significant vasogenic edema and mass effect on the lateral ventricles with subfalcine herniation and no ankle herniation or transtentorial herniation. So this is likely to be, I will put my main diagnosis to be glioblastoma multiforme. I'm thinking about there is a metastasis also to the bone, to the skull bone, with destruction of the nasal and the maxillary sinus. This is I would like to check the prior imaging of this patient. My my differential, this might be a case of lymphoma, but as lymphoma can cross also the midline, but due to this necrosis, I will put glioblastoma multiforme first. The other differential, this may be, but is less likely bone tumor, osteosarcoma in the bone would spread, but this is less likely. So this patient need urgent neurosurgical review, and they might need to do MRI brain also according to the patient condition. This patient need to be discussed in the neuro MDT as well, and further CT chest, abdomen, pelvis for staging.
Okay.
Thank you.
So you have given me the differences of lymphoma, glioblastoma multiforme, aggressive mass lesion, and necrotizing mass, basically.
Mm.
Anything else you can think of here, or anything else you would like to? Yeah, I mean, neurosurgeons would like to at least know. I mean, they are not gonna get this scan from you, a patient from you before MRI.
Mm. Yeah, so yeah, if I would like to check also the MRI for this patient if available.
Active sequences.
Okay.
In the interest of time.
Okay. Okay, this is the post contrast. Can I scroll or just comment on this one?
No, you can scroll just a second, please.
Okay.
You have the mouse now.
Okay, thank you. Okay. Actually, this is the MRI contrast study. I can see that there is ring enhancing noted within the part of the lesion with areas of avid enhancing. I'm not really sure, doctor. And there is also enhancing here in the nasal cavity. Uh, there's rapid enhancement in the nasal cavity. Okay. Is the lesion taking diffusion or there is no diffusion? I would like to check the diffusion restriction as well, if there is diffusion restriction as well. Okay. This is the ADC.
No.
This is diffusion. Okay, here is the diffusion. There is no. So, yeah, sorry. Now it's corruptible. I can't see area of diffusion restriction through diffusion restriction.
No,
So
no, no, no. You have high B value. If you scroll down,
okay. I think this is the last cut, doctor. I can't. Oh, yeah.
let's assume it's diffusion restriction. Let's assume, okay?
There is diffusion restriction. Okay.
Which sequence is this?
This is this flare.
Okay. And what do you see here in this sequence?
I can see that there is that lesion mainly in the nasal cavity and paranasal sinuses, and it's going up.
Would you like to reconsider your diagnosis, or?
Yes, yeah, I think this is maybe a nasopharyngeal carcinoma or no, ins- I can't remember the name. Incisioblastoma. The ones.
Is this esthesioneuroblastoma?
Yes,
Other word is
but I would like
olfactory
to I would like to check it in the T2 because it gives cribriform plate in T2. If I find it, it confirms that.
Yeah.
Uh,
Anyway,
it's not really, but I think now that the lesion is mainly from the nasal cavity in the paranasal sinuses, and it's invading the brain with destruction of the bone, rather than primary brain lesion. But I will keep this in my differential.
okay. Okay, that's fine. I think we had. I'll just stop you here. Today, I'm just trying to give more time to you. In exam, you will have to be very fast. Okay, we'll just discuss this first before discussing the first case which you were given.
Okay.
Okay, initially, first you were given this case. Okay, it's a CT scan without contrast.
Doctor, the screen is not there.
Sorry. Yeah. That's good that you reminded me. Okay, so this is a CT scan without contrast. Okay.
Yeah.
You were given this. I mean, this is a classic CT scan. I mean, I can even diagnose here as well, but obviously post contrast, it's a giveaway. So you see, there's a lot of soft tissue filling of these paranasal sinuses, especially the ethmoid hair cells. You know, see, there's a lot of, and then there's a lot of bone sclerosis.
Mm.
I would say bone. I wouldn't call it bone damage or destruction. I would say it's bone remodeling and sclerosis. That's one thing. Secondly, if you see, it's continuous with the, if you go up, see, there's no distinction. So this is continuously invading into the ethmoid cells and then even the olfactory bulb areas. See, even on non-contrast. Then the second thing you see are these cystic lesions. Yeah.
Mm.
And then third thing you see is obviously mass effect and edema. So these are main features. And then you got this contrast enhanced CT scan. Now, this gives you the diagnosis basically because it's a very avidly enhancing mass. Now, if you just track the mouse, this mass, you see the cribriform plate probably is destroyed. See,
Mm.
this mass basically arises from the nasal cavity in the olfactory bulb region, and then it just goes up and invades the intracranial area. Since it's coming from midline, it's going to the both direction, and then the hallmark of this is your neuroblastoma or olfactory neuroblastoma is those cystic areas between the mass and the normal brain. So that's quite I won't that's quite hallmark of this kind of malignancy or cancer.
Mm.
Especially when you can see the whole nasal cavity is stuffed with this mass and there's no distinction.
Mm.
Yeah. So it's a process which is arising at the paranasal sinus olfactory bulb level, and then this process is an extracranial process and going in intracranially rather than an intracranial process going extracranially. That shows that because how often you have seen uh, GBM or lymphoma going into the nasal cavity and stuffing it? How often you've seen it?
Yeah.
I haven't come
Never.
across any.
Never. Yeah.
Yeah, I haven't come across any. Maybe I'm no, I don't know. I haven't come across any. So,
Yeah. Maybe if I have asked for the coronal after this, I
so,
can.
yeah. So that's one thing. Okay, and then in
Mm.
the MRI as well, MRI is not adding much to the diagnosis. I mean, I diagnosed this case straight away on CT scan, and then MRI is a confirmatory test.
Mm.
So
Mm.
MRI is rather a diagnostic test here. Um, See. Same. So you can say MRI is confirming my initial suspicion of a process which is originating in the paranasal sinuses and the olfactory region and invading into through the skull to the cribriform plate, involving both frontal region. I could see the cystic spaces, so cystic areas between the mass and the normal brain, with a bit of enhancement. There may be a bit of calcification. Which is again found in these kind of masses. But the bottom line is this is heavily involving the nasal area, olfactory bulb area, and then going into the or invading, I would say, into the second thing, bone destruction. There's bone remodeling, bone sclerosis, rather than lytic lesions. So that's very important to differentiate. Normally it's a slow growing process. Hence the sclerosis of the bone and bone remodeling rather than aggressive mass, which is destroying everything in the vicinity. Okay.
Okay.
So that's one thing. So you were there. I mean, the process. So I wouldn't have failed you here. I would have given you just pass, like 2.
Mm.
I wouldn't have given you 0. I wouldn't have given you 1. I would have given you 2 in this. And then 3 is clear pass, and then 4 is excellent, as per
Mm.
the new marking scheme here. But your thought process is good. But I don't know why you jump on the diagnosis. Why the diagnosis come on? Never bring the diagnosis during the explanation. If you give
Yes.
the diagnosis during the explanation, because you gave lymphoma and GBM straight away. Why?
Mm.
Because in exam, if you give it, then your mind gets fixated those diagnoses, and then your whole time will be spent in justifying those 2 words you've uttered from your mouth. Then you've committed, and sometimes
Yes.
once you commit, then it's very difficult to backtrack from that. And it's a natural even psychology. You start defending those 2 words by trying to find the findings and try to fit those findings on those initial diagnoses which you have already expressed during the observational findings explanation. It's a rock model. I always say it's a rock model. This new exam is amazing. It's radiological observation, rock. So I was radiology knowledge, observation, and then clinical interpretation, communication. So there are a lot of things that are going at the same time. So you need to think fast. Okay,
Yeah.
don't be having a scattergun approach. The lymphoma, GBM, then then you say something else as well. Destructive region here, there. Then you jumped on those the extradural, sorry, scalp hematoma, subgaleal hematoma. Why? Okay, so just be focused. Try to be short and sweet. You're taking too much time in this, and I mean, you're wasting time in exam.
Okay.
Today, see, I am just seeing, showing you less cases. The quicker you are showing more cases, but anyways.
Okay. Thank you, doctor, for
So
your
the
feedback.
first one, no, the first one was, uh, okay, this one. The first one was very clear. You did very well. So it was a clear pass from my end. Three, you got three. Okay. So again, the approach was good, but you are spending too much time. Your knowledge is there, the explanation is good. Try to be slick and try to be focused. Okay. In exam, you don't have to describe each and everything. It's not a report you're typing. You have to be very focused. Talk where the money is. Go where the money is. Here, the money is in this periosteal reaction.
Mm.
Okay. So here is periosteal. There is subtle periosteal reaction here. Then there was here. There's a periosteal reaction. There was on the left side subtle, very subtle. Here you can see periosteal reaction. Here you can see periosteal reaction, bilateral periosteal reaction. So always think about paraneoplastic things. It's okay to think about hormonal, but always think about paraneoplastic syndrome in these kind of scenarios. And chest X-ray and the lung cancer is one of the main differential here. So you were right. You were right. You eventually reached there. I didn't help you at all. But we were babbling a lot of words. I don't want these kind of words. Just cut it down. Okay.
Okay.
You will do well in the exam, but just try to focus, okay? And don't get my help. I don't want to give you prompt. Every prompt I give you, okay, so tell me, then, so tell me, then what else could you think? What else, what if this is this? These are assisting areas. What do you think now? Every prompt I gave you will half a mark is deducted from your from the mark sheet. So you start with 4, then you go up to 3.5, 3, 2.5, 2, 1. So you reach a stage where you are borderline fail or just pass. You don't want that. Okay?
Yes. Thank you, doctor. Thank you for the
No
feedback.
worries. Candidate 3.
Good evening, sir.
Good evening. Limping child.
I've been presented with frontal radiograph of pelvis of a pediatric age group child who has been limping. I can appreciate there is a pubic symphysis widening. There is normally opacified bilateral femoral heads. The adjacent pubic symphysis bones are normal. A subtle bony osteopenia is noted. There is some sclerosis in the roof of the left acetabular bone. Within the sacrum, I cannot appreciate any abnormal lucencies. I would like to know if the patient has any prior history of any long-term condition.
No. Can you please show me where is the osteopenia? I've given you the mouse. Can you please show me where is the osteopenia you just mentioned?
Here.
I can't see the mouse hovering around. I've already given you. I will give you. Oh, yeah, you're able to control now. So show me, please.
Here.
No, that's the normal. No, that's the normal bone contour. Okay. So what do you think? A limping child. No previous history.
No previous history. I will be concerned about this pubic symphysis region, and I
Can
would
you show
like.
me again, please? Which pubic symphysis region? Can you show me?
There's the widening here,
Okay.
and there's a widening. I cannot appreciate any other area of periosteal reaction or any bone break, and also the lower lumbar vertebrae, they are not outlined properly. Could be due to the age of the patient, but that was also giving me a suspicion of having an osteopenia. It can be a part of a congenital disorder. So I would like to go with the bone screening. But first, before doing that, as the child is limping, I would go with the MRI for to assess the joints to look for any in underlying infective
So
cause.
in MRI request card is the child, obviously patient probably would need a general anesthesia to go through MRI. Child will not sit still in MRI. So obviously you are sending this child for a general anesthesia, MRI under GA. It's quite a big ask, I would say. What is your what are you suspecting? What will you write into your referral letter or a report? Why do you want MRI here?
No, I'm just trying to rule out any septic arthritic symptoms. This widening can be due to some congenital disorder like cleidocranial
So
dystrophy.
MRI for septic arthritis, you mean to say?
Yeah.
To rule out septic arthritis?
Yeah, if the child has acutely presented with some fever, constitutional symptoms with fever, then if a child has a background of like cleidocranial dysostosise or any congenital disease, he can have developed. So just trying to rule out that because
The child has no fever.
okay, then I will advise.
CRP is 2.
CRP is 2. Okay, so I will advise a skeletal survey and a lateral mandibular radiograph to look for any signs of mandibular angle widening. And
What does it mean?
I would also like to observe the child to look for any shoulder deformity and to look for any clavicular.
What are you thinking?
I'm thinking of cleidocranial dysostosis.
And what makes you think that?
There's a pubic symphysis widening, and it is associated with it.
Okay. So what should we do now?
So I will advise a skeletal survey and look for a chest radiograph if available. If not, I will request it.
Okay. Just for fun, we did another view.
So being presented with frog leg view of the same patient in which there is a widening of the physis noted on the left side with some irregularity along the physis as well. There is no evidence of any femoral head sclerosis or abnormality. And there is, okay, first I will complete this first. There is no evidence of any metaphyseal extrusion. So findings are in keeping with the early stage of slipped upper femoral epiphysis. Would like to compare it once again. Would like to see it once again in the frontal radiograph to look for the line of climb. But I think it wasn't much obvious in the frontal view. In the frontal view, there is only a subtle widening of the growth plate is noted on the left side, and the line is probably okay. Shenton line was also okay. So in this case, I will advise MRI to look for the status of the underlying bone. But I believe that at this particular stage, it is in keeping with early stage of slipped upper femoral epiphysis. I will advise and alert the referrer and will advise orthopedic consultation for the patient. It is most likely dealt with pinning, and patient should be need counseling and further follow-up radiographs to look for any development of secondary osteoarthritic changes which are not present in the current study.
What is the purpose of doing MRI?
To look for any underlying bony edema or changes. Look for
Anything else? That's one of the reasons. What is the second reason to do that?
Second reason, to look for the contralateral side if that is involved in the early stages, because there might not be any slip, to look for the contralateral side, because sometimes they do a prophylactic, they do pinning on the that side as well, because it is in 30% cases it is bilateral.
Okay. Someone presenting with ongoing abdominal pain.
So I've been presented with, I've been presented with contrast enhanced. I just want to start from the top side. Been presented with axial contrast enhanced CT abdomen and pelvis, lower chest and abdomen of a patient who presented with abdominal pain. I would like to scroll the study once before describing the findings. I would like to go till the last cut. So scrolling it once, I can appreciate that there is a diffuse bowel edema noted. There is ascites noted. There is enlarged liver. Stomach is dilated as well, and there are significantly dilated loop of the bowel seen. In the region of right iliac fossa, I appreciated a chunky area of calcification posterior to the cecal region, adjacent to the cecal region.
What do you think?
There is a loop of the sigmoid colon is thickened as well. Sigmoid colon is also showing thickening. There are multiple patch. There is ascites is noted as well as hazy mesentery. So I would like to see it in the coronal images in case I'm suspecting any intestinal obstruction with the transition point, which I could appreciate at the level of the right iliac fossa, at which I was also seeing a calcified lesion. So would like to see it in the coronal to rule out, as the patient is an adult. So I would like to see the right iliac fossa to rule out any cause of malignant cause. So this is the kidney probably, and the left there are multiple splenic varices noted as well, and aortic graft, aortic calcification is noted as well. Kidney is significantly displaced inferiorly. By the bowel loops, I would like to know if there is any prior history of surgery patient had, any previous. That there is a bulging of the kidney along the significant.
Can you show, please, with the mouse, please? Can you show me?
Here, this one.
Okay.
Okay, yeah, this one. And also, I'm trying to look for the left kidney, which is not appreciated. There are multiple splenic varices. Additionally, I can appreciate retroperitoneal nodes in the left side. And there is non-visualization of the left kidney. I would like to take a history if the patient has gone any, like nephrectomy for any prior renal cell
Patient had no history of nephrectomy.
no history of nephrectomy. No prior surgery.
Patient is vomiting and patient is in pain now in the department.
Patient is in the department. There is here. I would like to know the age and the gender of the patient.
How does it matter? What do you think? What is the gender?
I think it's the male patient and it's an adult.
You think it's a male patient?
No, it's a female patient. Can I see the sagittal images once? Because so these are the sagittal images and these are the bone window images in which there is a diffuse sclerosis of the vertebrae. Entire vertebrae is noted. This is a female patient and uterus is seen at its normal place. There are 8 shaped vertebrae noted and the vertebrae are showing dense sclerosis. So I would like to know if the patient has any known case of sickle cell disease. But the current study is suggestive of acute intestinal obstruction with an imminent rupture. So I would think of any. I would urgently communicate the finding to the gastroenterology surgical unit on call to assess the patient's status.
So you will tell the surgeons to assess the patient's status. Surgeons are relying on you for a report. So what do you think happening? What do you write in your report?
So there is an intestinal obstruction at the level of transition zone at the right iliac fossa, which urgently needs a laparotomy.
Show me again, please.
Here.
Where?
So at this level.
At this level, what's happening at this level?
Sir, can you see the cursor?
Yeah, I can see the cursor.
Beyond this, the bubble appears normal at this level.
Show me the abnormality.
This is the massively dilated loop, which is noted anterior to the kidney.
What loop is this? Large bowel, small bowel? What kind of loop is this?
It is a small bowel loop.
Okay. So then show me the large bowel, please, there.
I think that is the large bowel loop, and there is an intersusception going on at the level of sigmoid colon, and which is resulting in retrograde dilatation of the large bowel, and that is the massively distended descending colon as well as the transverse colon and the cecal region with an imminent perforation because the cecum is massively dilated and there is an adjacent free fluid as well. I cannot see any areas of free air adjacent to it, but the small bowel centrally is collapsed. It is lying in the central part of the abdomen. There is hazy mesentery and there are multiple lymph nodes as well. So I would again like to go to the region of interest to look for the cause of to see for any underlying lesion because there is an intersusception going on at the level of sigmoid colon. But I'm not able to find the cause. However,
Okay.
I would tell
what is the final diagnosis?
So the final diagnosis is colocolic intersusception at the level of sigmoid colon, resulting in massively dilated large bowel, resulting in might result in imminent rupture, and patient will urgently need a laparotomy.
Okay, thank
on
you.
the background of sickle cell disease.
Thank you. That ends the Viva here. Okay, so what do you think? How did it go?
Not
You only
good.
saw two patients, although you saw four modalities. You saw two patients. Okay, let's talk about this first. Okay, so you've been given a patient with a history of abdominal pain. Okay. Now, first thing first, when you see a scan, you just scroll through it, obviously from top to bottom, first slice to the last slice, and then you gather the information, assimilate the information here, and then speak your mind out. Problem here is, see, the moment you saw this, you were in kind of slight panic mode, slight, and then your knowledge is very good, I must say. You have a lot of knowledge. You've read a lot, I guess. The problem is to align your knowledge to a focused in a focused direction, and that is area where you need to work hard because there again is scattergun approach. You started with commenting on the thickened bowel loops, then this kind of interception, and then you were jumping on kidneys. You were worried why the kidney is not visible, and then why there's a bulging kidney on the right side. And you wanted to know about the previous nephrectomy history, if I'm not wrong. And then you wanted to see in coronal and it's a male patient or female patient, you were worried about that. So all those things are kind of irrelevant in acute setting. Yeah, in a chronic setting, then we can talk about it. So there are two things in this patient. One is acute issue, one is chronic issue. So this is an ideal case, a long case. It can be done as a long case. This can come as a short case as well. In a long case, it's a beautiful long case. Beautiful long case. So here, this patient has got colitis, intussusception, toxic myocolon, renal transplant, chronic kidney disease, and Ruger Jersey spine because of the chronic renal insufficiency. And also portal hypertension. So all first come first, we're worried about the pain. So you can clearly see there is a thickened bowel loops, yeah, thickened sigmoid. Obviously, when the wall is thickened, the peristaltic gets a bit sluggish, and there's a good chance of colocolic interception because of the impaired or disjointed or the synchronization is gone. So there's a good chance of having an interception in the setting. So there's a classic interception, colocolic, and then you can see the problem doesn't stop here. You can see the circumferential bowel wall thickening throughout. See, throughout. There's a sternoflexure, then there's a transverse colon. It's quite distended. Here is quite distended. And then there's ascending colon. It's a cecum. There's a loss of haustration of the bowel. And then there, the transition point you were talking about is ileocecal valve, where you see the normal terminal ileum. And the small bowel is completely collapsed. So that's the story number one. The second thing, so we have diagnosed colitis, pancolitis, with a degree of probably toxic myocolon. But pancolitis, you've got mesenteric congestion, you've got free fluid in the abdomen, then you've got interception. Enough reasons to call surgeons acutely. Secondly, you have somebody whose kidneys you couldn't see. You were worried about the left kidney, nephrectomy. How about the right kidney? So both native kidneys are atrophic. Yeah, completely atrophied native kidneys. So if you try, this is the adrenals. See, can you see this? This is the left kidney. Whenever you struggle, just go look for adrenals. and the right kidney, so, and the adrenal, and then right kidney here is hardly seen. Then we have got transplanted kidney or pelvic kidney on the right side. Okay, and then this is further confirmed by, it's a classic rugged jersey spine. Okay, so I don't expect. I mean, I would probably expect you to diagnose everything, but in a short, in a Viva setting, I want you to diagnose first of all acute problems to save your life, to save patient's life, and to save your life in Viva. So at least you can cross the red line of pass and fail. Then you can go for clear pass and excellent. You first need to reach the destination. So my request is, you need to be more focused. I mean, it's good to talk about kidneys, bulging kidney, absent kidney, spine, portal hypertension, varices, but these are I was switched off. When you were saying, I was completely switched off. I'll be honest. I was not interested. You got my attention when you say interception. Then I was switched off again when you're saying transition point in the right side. This is a complete, it's a pancolitis. If this cannot be appreciated as pancolitis, then what kind of inflammation you want? The complete loss of oscillation. And so that's something which, so every case in Viva, one needs to be 100% sure that there's a complete focus on acute findings first. I don't want to know whether there's a gallstone or not. I don't want to know whether there's a non-obstructive hernia or not. You can talk about it when there's a time, and you have aced the case first of all, and then you say, by the way, there's a gallstone and there's a non-obstructive hernia, but they are not of acute concerns. I'm not bothered. So in the conclusion, when you even do an on-call scan, the conclusion in the body of the report, you will mention about cholelithiasis without cholecystitis. But in the conclusion, you will mention that there's a pancolitis with acute interception, and then the mesentery is really congested. So it's urgent referral to on-call surgical team. That's it. And then you can talk about the native kidneys are significantly atrophied, and I can see the transplanted right kidney, question mark, any history of transplantation, because native kidneys are completely atrophied. And then this argument is supported by regurgency spine. Finish. In 5 minutes, you have finished the case, and that's it. So this is the approach I want from you guys. Rather than talking about all those things, no. This is an exam setting. Okay, so be focused. Okay? Be ready, be focused, be bold, and be gone. Okay? You don't want to be hovering around one case. Be bold, be gone. That should be the approach. Okay. Now, going back to your previous case. Now, first case, I was not very impressed, honestly. I must say. Never, ever, never, ever, never, ever you diagnose on one view. Never. It has to be two views. Where was orthogonal view in your discussion? Where was that? I never heard that. You never asked for orthogonal view. So you were trying to finish the case. And then, obviously this is a young child. These are all positional things. The genitals are not covered here, unfortunately. So it's the first scan. So I think they have deliberately uncovered it. But here they have covered it. So you do not talk about the things. You can say that, I cannot, even if you struggle to find any abnormality, you can say, okay, I'm struggling to find any abnormality on this single image, on a single view. Although I could appreciate there may be a bit of increased Pfizer distance or gap, but I cannot pinpoint, I cannot reach a diagnosis on this single view. So I want an ortho only, if available, please. Then nobody will stop you from giving. Here it's as clear as crystal. It's a Sufi. Full stop. I don't know what we're thinking about osteopenia and osteopenia here. These are bowel gas, overlying bowel gas shadows on the vertebrae. This is all bowel gas. This is bowel gas, all bowel gas. That means you're not enough, your eyes are not tuned to normal x-rays or normal abdominal x-rays. So X-ray is the weakest link. So you need to work hard on establishing the normal versus abnormal. It is important. Okay. So there's no osteopenia. So that's why I didn't. I mean, you were just borderline fail here, unfortunately, because I gave you this in the end when you had sent the patient for MRI for G and the GA for I don't know septic arthritis or God knows what. So don't bring second thing, important thing to anyone. If you don't know, do not make up the diagnosis. It's the biggest killer. I will not pass anybody who is fabricating the diagnosis. I mean, it's better to gracefully say, I do not know. I'm feeling myself stuck here. Unfortunately, in this case, I do not know how to proceed further. In real life, I would always seek help from my colleague, and we do all the time. Nobody's perfect. So it's perfectly all right to get a 0 here, move on, rather than getting 1 and then wasting your 30 minutes or wasting your 10 minutes. There are 6 cases. You don't want to waste that time there. Okay. So always ask for second view. See, you got the second view, you got the diagnosis within 1 minute, within 30 seconds, I guess. Maybe within 10 minutes, 10 seconds, I guess. So all those crap which you were discussing in the beginning was useless. Okay, you could have avoided it. All right. So your knowledge is a lot, but the correct use of knowledge. Now, all those, I mean, you were discussing about all kind of syndromes, shoulder X-ray and this X-ray, and I mean, unnecessary radiation. That's very discriminatory in a child. So try to be mindful of what you say. If you don't know, sit back, take a deep breath, have a pause, gather your thoughts. Just tell them, I'm going to think about it. Give me a few seconds, please, to think about it. Then again, go through the scan again. Have a look. Pause, sit back, pause, again have a look, think. Even then, if you don't understand what's going on, then move on. Then say, I've tried my best. I can't see any abnormality. During my time, I had the same case, one of the cases. I